Hi guys, I hope you had a happy Thanksgiving. I'm going to do a lecture here. My objective, just so you know with this lecture, is this material is not outrageously difficult, but it's kind of complicated. And so if you have a little bit more time to digest it, I think you're more likely to feel comfortable with it. So I'm going to do a lecture for most of the rest of this set of notes. Then I'm going to post a concept map for you guys that will also have a little video to go with it just to teach you how to read the concept map. It's the same material in the concept map that I'm going to be talking about here. And then when you guys get back on Tuesday, you're going to have a quiz that will be over the stuff we did last time, actually in class, relatively in-depth on that stuff. And then I'll go a little easier on this stuff because you didn't have me in front of you. After the quiz, we'll take time to discuss it, and we can go through the concept map, we can do all that kind of stuff. So it's not as if I'm not ever going to talk about these things in class. I just want you to get your feet wet with them and start figuring out what confuses you so that when we meet on Tuesday, you will not feel as overwhelmed. And so my plan is sort of half of Tuesday will be cardiovascular system physiology, and then the second half we'll start doing, I think urinary is next. All right, so I'm going to start today with Roman numeral 5, which is cardiac output. And so the concept that we've been talking about is basically the overriding function of the cardiovascular system is to ensure adequate blood flow to capillary beds. And of course, one of the components of ensuring adequate blood flow to capillary beds is cardiac output. And cardiac output is simply the concept of how much blood are you squirting from each ventricle per minute upon contraction. Now, even though it's each ventricle, just so you know, most of the time when people are talking about cardiovascular physiology, unless they tell you they are going to be talking about systemic circulation. Not because pulmonary is not important, but because, of course, there are more systemic vessels, there's more that can go wrong there. So assume, unless I tell you otherwise, that I'm talking about systemic circulation. So even though I say each ventricle, most of the time I'm going to be talking about the left ventricle. Okay, cardiac output is measured in some kind of a unit of volume per unit of time. Most of the time it's liters per minute. And so I want to see if this makes sense to you. Cardiac output is pretty much determined by two factors. If you are trying to determine how much is squirted per unit of time, then that is a product of how many times do you beat? Okay, how many contractions per unit of time? Here, number of heartbeats per minute. Think of that as number of ventricular contractions per minute, really. And the amount of blood that you eject per ventricular contraction. So that means that cardiac output is a product of heart rate, number of beats per minute, times stroke volume, which is the amount that is ejected per beat. So here's an adult example. At a stroke volume of 0.07 liters per beat, which is around a quarter of a cup, and a heart rate which is within normal of about 72 beats per minute, then the cardiac output, and this is an at-rest example, cardiac output at rest for this person would be about 5 liters per minute. It's rounding. But the impressive thing for that, of course, is that's about how much blood most of us have. So as I mentioned in the last lecture, at rest you pump almost your entire blood volume per minute. Okay, so what we're going to do now is we're going to sort of break down cardiac output and look at the factors that can impact cardiac output by either impacting heart rate or stroke volume. So hopefully that makes sense to you. Okay, once again, although most of you guys are not using it, interactive physiology is phenomenal for the cardiovascular system. It's a bunch of little logical relationships. So as you start studying this week, and if you start having trouble, you can go back to your textbook, or you can go onto interactive physiology and play with that. Specifically, the cardiac output part is helpful. Okay, so let's talk about controlling cardiac output. And the first thing that we're going to do is we're going to fiddle with stroke volume. Okay, so once again, stroke volume is how much leaves a ventricle, let's think left ventricle, per ventricular contraction. So how much blood do you squirt out per beat? And there are some factors that are actually going to impact this. One of them is the concept of afterload. And the other ones are going to be related to end diastolic ventricular volume. Okay, so let's talk about afterload. So afterload is the pressure that the ventricles are pumping against, which is the ventricles are going to pump blood into arteries. So I want you to think of the ventricles as generating P1, which is the pressure that they're generating, and what they have to overcome is P2, okay, in order to get blood to go the proper direction from ventricles to arteries. So as the arterial pressure against which the ventricles are pumping increases because of, for instance, arteriosclerosis or vasoconstriction or both, what's going to happen is the delta between the P's, the delta P, is going to decrease. So what I'm saying here is if you increase the pressure in the arteries, and you don't increase the pressure in the ventricles, then what afterload is going to do is it's going to decrease the amount of blood that leaves the heart per squirt. So afterload is the arterial pressure against which the ventricles are going to pump, and increased arterial pressure tends to decrease stroke volume. So what would make this afterload increase? So afterload will increase, and therefore stroke volume will decrease as a person gets high blood pressure. So as a person gets high blood pressure, what would happen is their stroke volume would drop, and therefore their cardiac output would drop. If you wanted to maintain the same cardiac output at hypertension, at high blood pressure, in order to maintain adequate blood flow to capillary beds, you might compensate by increasing your heart rate. If your stroke volume drops, then you might compensate by increasing your heart rate. Hopefully that will make sense to you. Okay, so that is the concept of afterload, and I've got a cool diagram that I'll post in the next video that will show you sort of how this relationship exists visually. Okay, so the next concept is this one, stroke volume and EDV. So first, let's define EDV. EDV is end diastolic ventricular volume, so it should kind of be EDVV. So let's break that down. End diastolic ventricular volume. First, hopefully you remember the concepts of systole and diastole. Systole is contraction and diastole is relaxation. So if you break this down, this concept of EDV is at the end of diastole, which is right before systole. What is the volume that is in the ventricles? Okay, so hopefully it will become obvious to you that EDV, end diastolic ventricular volume, is directly correlated to stroke volume. Or another way of saying this is what leaves the heart is directly correlated to what was in the heart before the ventricles contracted. So the volume of the ventricles just before contraction, right at the end of diastole, is the EDV, or end diastolic ventricular volume. So hopefully you'll see this relationship, increased EDV. So if you increase the end diastolic ventricular volume, then the relationship should be that you increase the stroke volume. Hopefully that's good with you guys. So if there is more volume in the ventricles, then there is more that is actually going to leave the heart when the ventricles contract. Okay, so now let's talk about the factors that impact EDV. And by the way, if you are confused by this, you will not be the only one. I want you to sit and ruminate on it, maybe even read your textbook about it, or go through interactive physiology about it. But this part, once we get through here, it'll ease up a little bit. Okay, so the factors that impact EDV, one of them is this concept of preload. So this concept of preload is the amount of tension in the cardiac muscle cells of the ventricles before ventricular contraction. And preload is really trying to acknowledge the fact that the cardiac muscle in the wall of the ventricles is not like a steel container. It has some give or flexibility to it. So the ventricles can be full, and then they can actually be more full. So not only can you increase the volume by just increasing the fluid, but you can also increase the size of the container. So keep that in mind for just a second. Okay, so the relationship here, so preload is what's in the heart, is what we're talking about, and you're going to be pushing against afterload. And we know that as afterload increases, then the stroke volume decreases. But as preload increases, it'll probably make sense to you that the stroke volume will increase. So as preload increases, stroke volume increases. And preload is impacted by two things. First off, how long do you give the heart to fill? So if your heart rate goes up too fast, then you are going to decrease filling time, and therefore you are going to decrease preload. So that means there is such a thing as too fast a heart rate. If your heart rate is too fast, you're not allowing enough time for the blood to actually fill. So filling time is dependent on heart rate. And so as heart rate decreases, filling time and preload will both increase. As heart rate increases, filling time and preload will both decrease. So if you give your heart a little longer to fill, then it will get fuller, right? And then you will get a better preload. Okay, and the other one is what happens in the ventricles is impacted by what's happening in the atria. So the atrial pressure, the blood that's in the atria is primarily there because of what we call venous return. And venous return is simply the passive return of blood through the veins to the atrium, primarily just based on pressure differences. But it can also be impacted by skeletal muscle contraction and respiratory system. I'll talk about that in a little bit. So atrial pressure, so how much blood is in the atrium is going to be directly correlated to how much blood is in the ventricles, which is going to impact EDV. Okay, so the other thing that can impact atrial pressure is when and whether the atria actually contract. So of course, when the atria contract, the pressure in the atria is going to go up. So these two things are going to impact this preload, which is of course going to impact EDV. Okay, so now let's talk about something that's related to this but slightly different. And this one's kind of interesting. This is called Starling's Law. And Starling's Law, let's see if I have a good picture of Starling's Law. They have one. Hold on just a second. I should have gotten this out before I started the video. It is a good picture. Okay. Okay, so this one is this cool little thing that allows for the heart to compensate when it's really full. It can actually beat harder. So Starling's Law says that if you get more blood into the heart, then the heart is going to beat hard enough to get all that blood out. Or as venous return changes, like as you get more blood in because of venous return, the heart automatically, without even consulting the endocrine system or the nervous system, the heart automatically adjusts its output to match the inflow, and this will prevent enlargement of the heart. And the primary way that this occurs is because as you get more blood into the heart, what it does is it changes the architecture of the cardiac muscle sarcomeres. So as EDV goes up, then what will happen is stroke volume goes up because of this little relationship. So this is a cardiac muscle sarcomere in a heart that is not completely full. And notice that if you have that relationship with your sarcomere, you get a decent stroke volume. But if the sarcomere is stretched, it actually works better when it's stretched. It's at a better optimal length and it has more access to cross-bridge cycling. And so what happens is cardiac muscle sarcomeres actually work slightly better when they're a little stretched, and that's what you're actually seeing here. So the increased venous return stretches muscle fibers in the heart wall, and then the muscle fiber is at a more optimum sarcomere length and it becomes better able to get a good contraction. So this is Starling's law, this relationship right here between EDV and stroke volume without involving the nervous system or the endocrine system. This is just this sort of ideal stretching relationship. Okay, now let's talk about how you can increase venous return to, for instance, cause this to occur. Increasing venous return, this picture is from the anatomy book because it's better than this BizBook picture. Increased venous return. So since the venous return, we know the blood in the veins is not dramatically impacted by the beating of the ventricles. They don't really even have any pulse pressure to speak of. So how can you increase the blood getting back to your heart, which is what venous return means? And there are two ways to look at this. The first one is called the skeletal muscle pump. And you guys probably know from anatomy that the veins in your appendages, especially, not all over the place, but in your appendages, have valves in them. And the valves help to compensate for the fact that the veins are really wide in their lumen and also relatively low pressure. And because they're relatively wide, low pressure, and also you're standing up and you've got gravity working against you, the blood in the veins would like to go backwards. But what we do is we keep it from going backwards because they're valves, and these are one-way valves. So as soon as you get it up here, if it tries to go backwards, then the valve closes. And so you can imagine it kind of ratcheting up, moving, moving. And when you contract your skeletal muscles, it pushes on your veins. When it does that, if you push on something with the one-way valve, you're going to force it up. So if your skeletal muscle is more active, then you actually get better venous return to the heart. So that's called the skeletal muscle pump. Your skeletal muscles actually contracting will help the blood move up to the heart. And then the other one is called the respiratory pump. And the respiratory pump is incredibly effective. So, of course, you have your thoracic cavity and abdominopelvic cavity. And the big division between them is that flat diaphragm. And so what is going to happen, this is the diaphragm when it's relaxed. Okay, this is before you inhale. And when you inhale, you go from here to here. And what the inhalation does is makes this cavity bigger, therefore dropping the pressure. This cavity smaller, therefore increasing the pressure. And what happens is blood, like all fluids, flow from high pressure to low pressure. If you increase the pressure here and comparatively decrease the pressure here, what you end up doing is you end up squirting the blood up your inferior vena cava every single time you inhale. And that's called the respiratory pump. And it's very, very effective. It's so effective that we don't even have any valves in the blood vessels in your entire abdominopelvic cavity. Like the hepatic portal system doesn't have any valves at all in it. Okay, so that is the skeletal muscle pump and the respiratory pump, and those both aid in the venous return. And then the other thing is, so like I said, the stretching in the walls of the ventricles causes the contraction to increase relatively passively, and you get more blood ejected. So exercise will actually increase the stroke volume, and it increases the stroke volume in a couple of different ways. It increases venous return. It'll also increase what the heart does. So exercise will increase stroke volume and therefore cardiac output. So the maximum amount that cardiac output can increase above normal is called your cardiac reserve. And one of the things that happens when you do cardiovascular training, like for instance, if you were a cyclist, is that your blood vessels get nice and cleaned out because of the increase in HDL, high density lipoprotein. and that will decrease afterload, which will increase stroke volume. And then in addition, your heart is trained to contract very effectively, which will increase your stroke volume as well. And one of the impacts of that is that your stroke volume goes up so much that your heart rate can go down, and therefore you can maintain the same cardiac output at a much lower heart rate, which is much healthier for your cardiovascular system long term, to beat hard but not very frequently to maintain your cardiac output. And then, of course, if you think about Lance Armstrong, who had a stroke volume about 3 times the normal amount, his heart rate could be very low. I think the last time I read, when he was at his prime, his heart rate was in the 30s, 30 something beats per minute. I think it was 37 beats per minute. But that didn't mean that he couldn't go up to above 100 beats per minute. So he had a tremendous amount of cardiac reserve compared to the rest of us. Because if your heart rate sits at 80 at rest, it can still go up to 120, but there's not as much difference between 80 and 120 as there is between 37 and 120. Okay, so so that's your cardiac reserve. Okay, so and then the other thing is that, and this is a little hard for people, they really confuse this with this concept. So I'm going to do it like comparison contrast. Okay, so what we just looked at a minute ago when we were talking about Starling's law is that we said that if you stretch the cardiac muscle cell sarcomeres a little bit, they work better. And I don't want you to confuse what I'm about to show you with this. This concept is ventricular contractility. And with this concept, you do not change the EDV. With this one, if you change the EDV, you change the stroke volume. This one, I'm holding the EDV constant, okay? So with this one, at a given EDV, you can increase the stroke volume by increasing the force of ventricular contractility. And the way that you do this is that, not this one, let's do this one. Okay, so the sympathetic nervous system, which we have known for ages, increases heart rate. The sympathetic nervous system also can increase not just the strength, the heart rate, but it can also increase the strength of contraction and therefore the stroke volume. And that is because of this hookup. So look here. So the sympathetic nervous system, don't let this confuse you. This is just going medulla oblongata to the thoracic region of the spinal cord. And then it's going to go out, right? And then the sympathetic nervous system is going to attach in the places you'd expect it to, SA node, also AV, which isn't shown here. But then the important thing is the sympathetic nervous system also attaches to the actual wall of the ventricle. So what this one can do is, instead of just talking to the pacemaker cells, it also has some capacity to talk directly to the contractile cells. So what happens is the sympathetic nervous system can not just increase the strength of contraction, increase the rate of contraction, and it can also increase the strength of contraction. So that means that if you look back to here, if the sympathetic nervous system were applied, it would have a massive impact on cardiac output, because we have known for ages that the sympathetic nervous system would increase heart rate. But now I'm also telling you it makes the heart beat not just more frequently, but also harder, okay? And it does that just by stimulating those contractile cells. Okay, so the sympathetic nervous system increases ventricular contractility without doing anything to the EDV. So the sympathetic nervous system can do it by releasing it as a neurotransmitter, and then also the hormone epinephrine could do the same thing. It would increase not just heart rate, but also strength of contraction. So you guys already have assessed this, or we've already talked about it. So if, for instance, a person is bleeding out, or if they just had a heart attack, so their myocardium is really weak and they don't get a good stroke volume, how would you maintain cardiac output? If your stroke volume falls, then the way in which you can maintain cardiac output is by increasing your heart rate. So even though it sounds counterintuitive, remember that what we're trying to do is to deliver adequate blood flow to capillary beds. And so if you're bleeding out, what will happen is you will get a higher heart rate, not a lower heart rate. Okay, so all of that is stroke volume. People have the hardest time with EDV, and I will give you the opportunity to ask questions about that on Tuesday when I see you. And also right after this lecture, I'm also going to post a short one with a concept map that shows you sort of a visual relationship, which helps some people get the relationship. Okay, so now we did stroke volume, and now we're going to come back and do heart rate. So the other way to regulate cardiac output is by regulating heart rate. Luckily, with heart rate, we already know most of this because, of course, heart rate is primarily manipulated by the autonomic nervous system. And then you're going to have a couple of hormones that can do the same thing. So the factors that are impacting heart rate, autonomic nervous system control of heart rate. So we already saw a little bit of it here, but this gives a little better visual for it. So I don't know if you guys remember this, but hopefully you do. The medulla oblongata is the part of your brain that makes decisions, involuntary decisions, unconscious decisions, or subconscious decisions about your heart rate. So the medulla oblongata decides whether to turn on the parasympathetic nervous system, which goes through the vagus nerve, cranial nerve number 10, to the SA node and the AV node, which would decrease your heart rate. Or the medulla oblongata can also send a signal down to the thoracic region of the spinal cord to activate the sympathetic nervous system. And the sympathetic nervous system will go to the SA node and the AV node. Those two regulate heart rate, but now we just learned that the sympathetic nervous system can also regulate stroke volume by going directly to the ventricular myocardium. And we're not talking about that part right now, but just to reinforce that. Okay, so you have inside your medulla oblongata, they call them medullary because of where they are, cardiovascular control centers. And they regulate cardiac muscle contraction, and they also will do whatever is consistent to the vessels, and I'll come back to that in just a second. So part of the medullary cardiovascular control center is connected to the sympathetic nervous system. Sometimes they call the little chunks that are connected to the sympathetic nervous system, they call those cardioacceleratory centers, and the ones that are connected to the parasympathetic, they call them cardioinhibitory centers. That's not particularly important, but really it's just these parts of the medulla oblongata. Cardioacceleratory and cardioinhibitory centers. Okay, so let's talk about the sympathetic one. So if you turn on the sympathetic one, then what's going to happen is you are going to send an action potential down to the thoracic region of the spinal cord, and then you're going to send it out. This is the preganglionic neurons, and these are going to be the postganglionic neurons. And then it's going to synapse at the SA node and the AV node. SA node, AV node. And we know what it's going to do. It's going to release the neurotransmitter, primarily norepinephrine, and it's going to increase the heart rate by communicating with the SA node and the AV node. It will also, of course, increase strength of contraction, but we're not concerned with that right now. So what type of receptors are involved? Hopefully you remember that those are beta-adrenergic receptors. Or administering epinephrine clinically has the same effect. So you can probably see why epinephrine is a really, really good treatment for crashing blood pressure, which is cardiovascular system shock. Because remember that epinephrine is going to hit cardiac output two ways. It's going to hit heart rate and stroke volume, and that's a pretty powerful way to increase your cardiac output and therefore your blood pressure. In addition, epinephrine also causes vasoconstriction, which will also help to increase your blood pressure. Okay, what about parasympathetic nervous system? The parasympathetic nervous system, again, is going to go primarily through the vagus nerve to the heart. And so what's going to happen if you communicate via the vagus nerve? You would come from the medulla oblongata. This time you would come from a chunk of gray matter called the cardioinhibitory center, and you would send out action potentials along the vagus nerve. long preganglionic, short postganglionic, if you remember that. And it would go to the SA node and the AV node, and then it would secrete acetylcholine, okay? And acetylcholine would decrease just the rate of contraction. It wouldn't have any direct impact on the strength of contraction. It's not hooked up. The parasympathetic nervous system is not hooked up to the ventricular myocardium. And these, of course, are going to, it's going to be cholinergic receptors. These are going to be cholinergic receptors. Okay, so back to what we said before. Normally what's happening is parasympathetic nervous system activity is far more frequently active on your heart. So if you cut all of the autonomic nerves to your heart, as we said, the heart rate will speed up to around 100 beats per minute at rest. And the autonomic nervous system regulation, primarily what we have said is you turn this one on because of feed or breed, and you turn this one on because of fight or flight. And now what we will get to in just a second is that's a little simplistic. We actually can turn them on for other reasons, and we'll come back to that in just a second. Okay, so hormonal control of heart rate. So now let's talk about hormonal control of heart rate. This is pretty easy. You've already learned these hormones. The two primary hormones that have the most direct impact on heart rate are, of course, epinephrine. As a hormone, you guys know that it's secreted by the adrenal medulla during sympathetic activity. And epinephrine increases heart rate, of course. It also increases strength of contraction. And then the other hormone that's pretty dependable at increasing heart rate is thyroid hormones, T3 and T4. Now, those will cause an increased heart rate, not dramatic, but for a longer duration. And the way to think about this is just simply that someone with untreated Graves' disease would have a higher metabolism in their cardiac muscle cells and in almost every other place as well. And it tends to have a pretty small but very long-lasting effect on increasing the heart rate. If you, however, have hypothyroidism, like Hashimoto's disease, it decreases your heart rate. Again, not dramatically, but over a long period of time. Other factors that influence your heart rate. So your heart rate can be motivated to be increased by other things. First off, let's just remember that, of course, your brain is going to be hooked up to this entire thing. We know that you can activate the sympathetic nervous system because you're exercising, but you can also activate the sympathetic nervous system because you're freaked out, or because there's a tiger in the room, or you're having a bad job interview, or you have that sort of not negative stress, but that's also stressful, like you get on a roller coaster. So emotions can impact the heart rate. The direct way to do it is via the autonomic nervous system. They can also do it via stress hormones. The other thing is, since your cardiac muscle contraction depends on potassium, sodium, and calcium, if you get any of those abnormal, then you can impact your heart rate. You can cause cardiac arrhythmias, like with hypokalemia. You could cause heart attacks with hyperkalemia, and there are calcium and sodium disorders as well. Endurance training, like we were talking about with Lance Armstrong, what that tends to do is to impact your heart rate long term. Now, I'm not talking about when you are training. I'm talking about the long-term effect of endurance training. That tends to be to increase your stroke volume so your heart rate can go down and still maintain the same cardiac output. And then the other one is this one, just this temperature control of heart rate. As you increase your body temperature, your diffusion will go more quickly. And remember that the SA node all starts because of sodium diffusion inside the cells. And so basically you're just increasing the movement of any atom or molecule at higher temperatures, including this one. So if you increase your body temperature, your heart rate tends to go up a little bit. If you decrease your body temperature, your heart rate tends to go down a little bit. But also your oxygen requirements go down at lower temperatures. So it's not that big a deal that your heart rate goes down. Okay, so let's just do a little clinical connection, talk about congestive heart failure. In order to understand this, you have to really remember where blood is coming from and going to. This is just a little clinical connection that kind of brings the whole story back together. So, congestive heart failure is sometimes called venous congestion. And so, what's going to happen here, and we could use any heart picture, but let's just use this one because it's already here. Okay, so what I want you to think about with congestion is I want you to think about kind of like a traffic jam. And with congestion, what you're going to end up with, the way the congestion actually starts is that you have one of your ventricles, which is too weak to actually do its job really effectively. So you can either have a weakened left ventricle or a weakened right ventricle. And what happens is if the ventricle is too weak to get the blood out, then the blood starts to back up. So of course, from the right ventricle, it would back up from right ventricle into the right atrium, and then ultimately it would back up into the vessels that were at the end of systemic circulation. And then it's going to keep backing up and backing up over time until it gets into the porous capillaries. So that's what would happen with the right heart. And so let's talk about the right heart for just a second. So with either side congestive heart failure, you get a decreased cardiac output and therefore a decreased circulation. But really, it's the congestion or the traffic jam that's going to cause some pretty massive symptoms. So if you have a failure of the right heart, what happens is you're going to back the blood up until you get into some capillaries. If you have capillaries that already have trouble with venous return, like the capillaries that are at the in your hands and your feet, because those are dealing with low pressure and they're also working against gravity, then what you tend to get if you have failure of the right heart is back up from right ventricle to right atrium to, of course, the superior and inferior vena cava. But then ultimately you keep going until you get back to the systemic capillaries that are hard to return blood from. And then you get peripheral congestion. So if you wake up with swollen feet, even in the morning, and you haven't eaten 3 bags of Cheetos or an incredibly salty Thanksgiving dinner, if that happens regularly, that can be an indication of failure of the right heart. Failure of the left heart, so again, you need to think about the traffic jam. If the left ventricle is too weak, it backs up left ventricle to left atrium, right? And then from the left atrium, it backs up into the pulmonary veins, and then it backs up to the lungs. So what can happen there is it can cause pulmonary congestion as you push fluid into the capillaries of the lungs, and you start having shortness of breath, especially when you're lying down. So I'm going to show you guys a video that will address congestive heart failure as part of this lecture. It's only 2 minutes long, and it's actually made for patients, so it's really not very jargony.
Your heart is a beating muscle that pumps oxygen and nutrient-rich blood to your body through the circulatory system. Inside your heart are 4 chambers that are responsible for collecting blood and then redistributing it to your lungs and body. Several conditions can impair the heart's ability to effectively circulate blood. Defects or diseases of heart muscle or the heart valves and coronary artery disease can result in a failure to maintain an adequate circulation of blood to satisfy the needs of the body. And high blood pressure and narrowed or clogged arteries can increase the resistance to blood flow through the vessels, thus increasing the workload of the heart. Any of these conditions can result in an enlarged heart with compromised function. Eventually, the failing heart cannot pump out what is being delivered to it, and pressure builds within the heart chambers and venous system, causing an accumulation of fluid in body tissues. This progressively worsening series of events is called congestive heart failure. As CHF progresses, swelling often occurs in the legs and feet, and fluid may collect in the lungs, causing shortness of breath. Eventually, heart failure may affect the function of the kidney, further increasing fluid accumulation and perpetuating this unhealthy cycle. The symptoms of CHF are treated using diuretics to eliminate excess fluid. The primary cause of CHF will then be targeted using medications to increase the pumping ability of the heart or decrease blood pressure, thus lessening the amount of work the heart has to perform. In the case of valvular defect, surgical intervention may be required.
Okay, so your heart will actually increase in size if it can't keep up with what's going on. And I don't know how many of you guys remember there is a cadaver on the Redwood campus that he's had 2 or 3 bypasses, and he had a pacemaker, and his heart is just enormous. It's about 1.5 times the size of a normal heart. He had congestive heart failure. So how do you treat it? Well, remember, anytime you're dealing with pressure problems, you can you mess with pressure problems with vessels, fluid volume, and pump. So digitalis is a medication that actually causes your heart to beat less frequently, but more completely every time it beats. It's derived from the foxglove flower. It's been around for ages. It's a really cheap medication. It's pretty effective. And then diuretics, if you are having trouble keeping up with the pressure of the system, then you can reduce the pressure by reducing some of the fluid volume. Or if you can cause vasodilation in the system that you're pushing into, you can effectively get the blood through a little better. So basically, again, whenever you're dealing with pressure, pump, volume, vessels. Okay. So the last thing that we're going to do is just this stuff, the mechanisms of controlling pressure. It's not as complicated as it looks. Let's see. Okay, so this leads directly into what we've been talking about. So we've been talking about cardiac output, and now we are going to sort of leave cardiac output, not completely though, and we're going to talk more globally about mechanisms of controlling blood pressure. Obviously, blood pressure is partially controlled by what your heart is doing, but it's also impacted by what your vessels are doing and by your fluid volume. So the ways in which you want to control blood pressure have to do with heart, vessels, and fluid. And for instance, if I had a hormone that impacted the heart, the hormone that was trying to regulate blood pressure and impacted the heart and increased heart rate, that same hormone, we would use that rule that we found before. If a hormone actually has impacts on 2 different body systems, it's not going to contradict what it did in one place with what it does in the other place. So for instance, if you had a hormone that increased heart rate, you would expect it to also, if it had any impact on the kidneys, it would cause water retention, not water loss, because increased blood pressure, both of those. So let's look at this sort of trend that we have here. So with the autonomic nervous system, we've already pretty much done this, but we just need to add in just a little bit more detail. We said that the autonomic nervous system gets to control blood pressure, and we know that it does it primarily 2 ways. It is going to do it by impacting what the heart is doing, and it's also actually going to impact what the vessels do. So autonomic nervous system control of blood pressure. This is short-term regulation when compared to, for instance, endocrine regulation. Okay, so the question is, what ways can you decide to turn on or off the cardiovascular system, autonomic nervous system input to the cardiovascular system, other than fight or flight and feed or breed? And so here's the next way that you can do it. So in addition to your body sort of consistently monitoring whether there's a tiger in the room or whether you're just chilling, your body is also monitoring its own pressure. So there is sensory input that is being gathered from these baroreceptors or pressure receptors. And you can use the pressure regulation that's being monitored to figure out whether you need to turn on your sympathetic or parasympathetic nervous system. So I'm going to show you an animation in just a second, but let's just give you an idea of where these things exist. Okay, so first thing is that you have baroreceptors in a couple of different places. Let's do the arterial ones first. We have the carotid sinus reflex, and hopefully you guys remember where your carotid sinus is. You are monitoring pressure in the carotid sinus, and these are in these two. The carotid sinus is right where you give rise to the internal carotid arteries and the external carotid arteries. And the internal carotid arteries supply most of the blood supply of the brain. And then the other place that you have arterial baroreceptors that are really important are in the aortic arch. Now, the aortic arch is monitoring pressure to the entire systemic arterial circulation, and the carotid sinus is doing a similar thing, but it's more persnickety because it's monitoring blood pressure to the brain. Okay, so here's what's going to happen in either of these locations. These are sensory receptors that are embedded in the walls of these vessels. And if they detect high levels of pressure, they are going to send that sensory input to the medulla oblongata of the brain. And the medulla oblongata of the brain is going to use that information to decide subconsciously whether to turn on the parasympathetic or on the sympathetic. So, give you an example, and then I'll show you guys an animation. What would happen is, let's say I detected high pressure in the aortic arch or the carotid sinus. That sensory information goes to the medulla oblongata of the brain. The medulla oblongata of the brain says, high systemic arterial pressure. Do I turn on the sympathetic or on the parasympathetic? High pressure systemically, I need to turn off the sympathetic and on the parasympathetic to drop the pressure. It's just a little negative feedback inhibition loop. So what is the difference between these two? This one is monitoring pressure to the entire system. This one is primarily monitoring pressure to the brain. This one is easier to piss off than this one. This one is also more subject to changes in body position. So for instance, if you get up really quickly, this one will trigger even if this one doesn't. So if the pressure dropped because you got up really quickly, this one would say, oh, not enough pressure to the brain. You just went from laying down to standing up. And so if the pressure was inadequate to supply blood to the brain, it would say, okay, send that sensory input to the medulla oblongata. Medulla oblongata says, too low, that pressure is too low. And what it would do is say, okay, the pressure is too low in this important systemic artery. And it would send an impulse back to the sympathetic nervous system to increase pressure. Okay, so I'm going to show you guys an animation that goes with that.
Increased blood pressure stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation. Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata. As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate. Also, as a result of the increased stimulation from the baroreceptors, the cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume. Okay, so just to make sure you understand this part before it goes on. This said that the pressure was high. This is not actually the carotid sinus, so don't get confused by that anatomy. But they were trying to show aortic arch and carotid sinus. If the pressure is high, it sends sensory input to the medulla oblongata, and then the medulla oblongata says, slow down sympathetic. Oh, sorry. Is that what it did? Yeah. Slow down sympathetic. And slow down sympathetic. There we go. And increase parasympathetic.
And then what it's going to do is it's going to do something consistent with the vessels. So if you had high pressure and you worked to decrease the pressure, then what would you do with the vessels that would be consistent? Would you do vasoconstriction or vasodilation with the vessels? So
The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal. If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
okay, so that was baroreceptor. And basically all it was a little negative feedback loop that if you encountered high pressure in these systemic arteries, they sent a signal to the medulla oblongata, sensory signal, and the medulla oblongata responded by decreasing sympathetic stimulation and increasing parasympathetic stimulation, and also causing vasodilation. Okay, so the only difference between these two is sometimes they would both be activated, but this one is more tweaky because the blood pressure of the brain has to be very narrowly constrained, and also it's subject to changes in body position. Okay, so that's the aortic arch reflex and the carotid sinus reflex. They're pretty much the same idea, just different pressures. Now this one confuses the heck out of people. So this is the right atrial reflex, and your textbook doesn't have a picture of it or anything. So I want you to think about the right atrium for a second. Here's the right atrium, which is the end of systemic circulation. And the right atrium is really the end, right? So if systemic circulation starts at the left ventricle, it ends at the right atrium. So think about that as we're going through this. Okay, so the right atrial reflex does not respond to arterial pressure as the other two. The other two were in arteries. The right atrial reflex responds to venous pressure. So here what you have is you have pressure, again, sensory receptors for pressure in the superior and inferior vena cava and in the right atrium. And what those are doing is those are detecting venous pressure. And so what will happen is increased venous return. For instance, like if you started exercising and you increased your venous return, what it would do is it would stretch those. And then those would respond by sending a signal to the medulla oblongata, and then the medulla oblongata would have to figure out what to do about that. So what I do is here I'm having an increased amount of venous return to the right atrium, and then I'm going to tell the medulla oblongata about it, and the medulla oblongata has to figure out whether to turn on the sympathetic or the parasympathetic nervous system in response. But this one takes a little bit of thinking. So what's going to happen here is as I get increased venous return, I tell the medulla oblongata, and the medulla oblongata doesn't say, hey, I should probably decrease ventricular contraction. Because I want you to think about that. If I had a whole bunch of blood going back to the atria, and then I said, oh, let's slow down the heart rate, what that would do is add to the problem and potentially cause congestive heart failure. What really needs to happen is I need the ventricles to keep up with what's happening with the atria. So strangely enough, if I have increased stretch in the right atrium, I will activate the sympathetic nervous system, not the parasympathetic nervous system. And what it's going to do is when venous return is really high, then you need to increase your heart rate. You will also, of course, with sympathetic stimulation, increase the strength of contraction. And so what you're doing here, the right atrial reflex is really about output keeping up with input. And what it's going to do is get more blood out of the system. Okay, it will also increase sympathetic stimulation to the vessels. It will cause vasoconstriction to get things moving a little better. Okay, so that's the right atrial reflex. Now, please note that atrial and arterial are spelled very similarly, but they are completely opposite in how they behave, so you're going to have to pay attention to that. Okay, so then the last part is just sensory input. So one more time in these same locations. not only do we have baroreceptors, we also have chemoreceptors. And these chemoreceptors are monitoring the content of the systemic arterial blood. And they are monitoring it for exactly the kinds of things you would think. They're monitoring oxygen content, they're monitoring carbon dioxide content, and they're also monitoring pH/H+. Hopefully you guys remember the relationship between carbon dioxide and pH. As your carbon dioxide goes up, CO2 plus H2O yields H2CO3, which dissociates to H plus and HCO3 minus. And so there is a direct correlation between carbon dioxide content and H plus content. There is an inverse correlation between carbon dioxide and pH, right? As your carbon dioxide goes up, your pH tends to go down. So what happens in these locations is you're going to monitor the content of the systemic arterial blood to decide whether to turn up the heart rate or down the heart rate. So same kind of thing we're going to have is that we are going to monitor, like right here and right here. We're going to monitor if we run into low levels of oxygen, high levels of carbon dioxide, or low pH. We are going to send that information via the sensory nervous system to the medulla oblongata, and the medulla oblongata analyzes that information and says, do I need to turn up the sympathetic or up the parasympathetic? So I've got an animation for you guys on this one too. So I'll show you this one.
Chemoreceptors in the carotid and aortic bodies monitor blood oxygen, carbon dioxide, and pH. Impulses from these chemoreceptors are conducted to the control centers for heart and blood vessels via the glossopharyngeal and vagus nerves. Chemoreceptors in the medulla oblongata monitor blood carbon dioxide and pH. Decreased blood oxygen, increased carbon dioxide, or decreased pH decrease parasympathetic stimulation of the heart, which increases the heart rate. Decreased blood oxygen, increased carbon dioxide, and decreased pH increase sympathetic stimulation of the heart, which increases heart rate and stroke volume.
Okay, so before we go any further, this said that if you detected low oxygen, high carbon dioxide, or low pH in either the carotid sinus or aortic arch, you're going to send all that information to the medulla oblongata, and the medulla oblongata is going to say, what do I need to do about this? Well, it means low oxygen, high carbon dioxide, or low pH in a systemic artery means that your blood is not pumping effectively enough. And so what it's going to do is it's going to decrease parasympathetic stimulation and increase sympathetic stimulation, which will increase cardiac output. And then what are you going to do that's consistent with the vessels?
Increased sympathetic stimulation of blood vessels increases vasoconstriction.
Because if you vasodilated, you would drop blood flow because you would drop the pressure.
Chemoreceptors in the carotid.
Okay, so that's the chemoreceptor reflex. Basically, if you have something that looks like you're not getting enough blood flow in these systemic arteries, you need to increase blood flow. If you had the opposite input, you would have the opposite response. Okay, and then the last part here is just to look at what the hormones do. And so you should be able to fill this one in at home. You know all of these hormones except this one, okay? All right, so we just did nervous system control of blood pressure, and now we're doing hormonal control of blood pressure. And then what I'm going to do is I think I'm going to stop right there. Yeah, I think I'm going to stop at renal, and we'll do renal in class, and we'll make sure that you've got this filled in too. Okay, so hormonal or endocrine controls of blood pressure. So again, the ways that you control blood pressure are pump vessels volume. So you should know the answer to the vast majority of these things. So epinephrine comes from the adrenal medulla during sympathetic stimulation. And the effect on the vessels is it causes mostly vasoconstriction, net vasoconstriction. And the effect on the heart is it causes an increase in cardiac output. So the net effect on the blood pressure of doing both of those things is to increase the blood pressure. Okay, ADH comes from the posterior pituitary. The effect on blood volume, of course, it goes to the kidney and it causes water retention or water reabsorption at the kidney, which would increase your blood pressure. And it does whatever is consistent with the vessels. Its other name is vasopressin, so it causes vasoconstriction. The net effect of those two together is to increase blood pressure. I'll come back to this one in just a second. Aldosterone. Aldosterone comes from the adrenal cortex, and it causes sodium retention at the kidney, which will cause an increase in blood volume by also causing water retention. So the impact of that on blood pressure is to increase your blood pressure. EPO doesn't have a direct impact on blood pressure, but it does have an indirect impact on blood pressure. EPO, or erythropoietin, comes from the kidney. It increases blood volume because it puts more red blood cells in there, which increases blood pressure. And then we already met ANP or ANF. It comes from the atria of the heart, and it is released in response to prolonged atrial stretching, not just one-time atrial stretching. And what it does is it will target the kidneys to decrease blood volume by basically making you pee out more sodium and water. And it does whatever is consistent with the vessels, which is vasodilation. It's really the only hormonal decreaser of blood pressure. And then let's just do this one. Okay, angiotensin 2, which you really haven't learned yet, and it's right after this in this set of notes, but I'm kind of done talking right after this. So angiotensin 2 kind of comes from the kidneys. You can put an asterisk there, and then I'll explain what I mean by kind of when I see you guys next. And angiotensin 2 can trigger the adrenal cortex to release aldosterone, which would, of course, have this impact of increasing your blood pressure. And angiotensin 2 is also the most powerful vasoconstrictor in the body. And if you cause aldosterone release and cause vasoconstriction, then your impact on blood pressure is to increase. Okay, so the tip is that any hormone that increases blood pressure can do it in any combination of these three ways. Vasoconstriction, make the vessels smaller, increase cardiac output, or increase blood volume. Hormones that decrease blood pressure do any combination of the opposite. And so you should be able to know what those do. Alcohol is an interesting one. Alcohol actually drops your blood pressure. Now we're talking about not excessive quantities of alcohol. Alcohol drops your blood pressure because it inhibits ADH release, so it's actually an anti-diuretic. That means it's a diuretic, which would have a blood pressure reducing effect. And it also inhibits vasoconstriction because it actually impacts your medulla oblongata and inhibits vasoconstriction of your vessels, which causes the flushed appearance of the face, and it also drops your blood pressure because of that. Okay, so that's enough. And I know you're probably a little overwhelmed by this, but when I get a minute, I'm not sure if I'm going to do it right now or later today, I'm going to post a concept map that helps you understand all of this stuff.